Hi, my name is Marla Neufeld, and welcome to the Surrogacy Space. I'm a reproductive attorney in South Florida, and I'm joined today with Dr. Lindheim and Dr. Reggio from Elite IVF Solutions in Weston, Florida. Thank you both so much for joining us today on the show.
You're very welcome.
Our pleasure.
Yeah, so I've been dealing with Dr. Lindheim with a lot of issues going on in Florida. He's been a great advocate supporting Florida's surrogacy laws, and I'm so grateful for all the feedback and input you've provided. So I just want to start with thanking you for your support of our protecting Florida surrogacy laws.
My pleasure. It's a
Yeah, so
big passion of mine.
yes, and it's apparent from the moment we first spoke that you have great ideas and you're very supportive. So it's great to see. And so, just for our listeners, Dr. Lindheim is a reproductive endocrinologist at Elite IVF. He's a professor at University of Central Florida and has a ton of experience and years of practice in reproductive medicine. And Dr. Brett Reggio is the laboratory director at Elite IVF Solutions and certified as a high complexity clinical laboratory director. And so I look forward to learning more about both of your expertise. So, Dr. Lindheim, we can start with you. What inspired you to focus on reproductive endocrinology and infertility?
Well, first, I'd like to say most people refer to me as Steve or Dr.
Okay.
L. So you can call me
Okay.
if you'd like, but it was the ability to help people get pregnant was incredibly alluring to me, but probably the most fascinating part of it when I got involved in this back in the mid to late 1980s was the ethics because there were no ethics. We didn't know the boundaries. We didn't know a lot of things. And so watching it on a day-to-day basis of uh, multiple different things from donor sperm to donor eggs and just the infancy of gestational surrogacy was so fascinating to me, and it drew me in.
That's awesome. You've really been around through the whole time of surrogacy. Our laws are 30 years old, so in Florida. So you're definitely very experienced in this area. And I know that Elite IVF Solutions is relatively new to South Florida and Weston, but where were you practicing before?
Most recently, I was at Baylor Scott and White in Temple, Texas, and
Okay.
I was the program director for the IVF program, as well as the associate chair or the vice chair for clinical and translational research.
Wonderful. And are you enjoying South Florida life?
Love it, love it, love it,
Awesome.
love it.
Great. Well, I'd love to hear a little bit about Elite IVF Solutions. I know you've been practicing under the clinic, but you're about to have the big opening with beautiful facilities. So what makes it special? What type of patients are you going to be primarily treating? Just let me have, for our listeners, a great overview of Elite IVF.
Brett, I'm going to let you take that
Sure.
away initially, and then I can chime in afterwards.
Sure, I'd love to talk a little bit about our laboratory, if I may. We have, you're always going to hear laboratory directors talking about we have the state of the art, this and that. And pretty much we do, right? We have time-lapse incubators, which allow us to culture the embryos in an uninterrupted state for the entire culture period. And the reason it's important is we don't disturb the embryos to observe them. We have the camera do that. And so it makes it much
Mm.
more efficient and safe for the embryo to keep it in its nice little cocoon during the entire culture period. So we have a number of time-lapse incubators that allow us to keep our patients' embryos nice and safe. Speaking
Very
of safe,
interesting.
we also have an alarm system that monitors every piece of equipment that we have that an embryo or sperm or eggs would be cultured in. Every piece of equipment is monitored 24 hours a day, 7 days a week by a live person that would,
Wow.
at the end of the monitoring line, that would call me in the event of an excursion in the parameters of the equipment. And if
Mm.
I don't answer the phone, then they will call Stephen, and Stephen will get a hold of the right people to go ahead and take care of whatever needs to be taken care of.
I mean, that's hugely important, especially in South Florida with weather and everything that goes along. And it makes me think of
We
that Alabama case where maybe the alarms weren't working so well with the,
Right.
the birth.
They didn't have a locked door to prevent anyone from entering. Each of our corridors leading up to the IVF lab and the IVF lab door itself are all access controlled. Um,
Wow.
and then we have an emergency generator, speaking of the weather here in South Florida. So if
Okay.
we did lose city power, the generator comes on to provide days worth of electricity in the event of an extended power outage.
Wow. I know where I'm going if my power goes out then.
Yeah.
Well, I'd like to just echo one thing that Brett said. When we put our mission statement together, um, it was really important to us to say that we have the state-of-the-art facility, the state-of-the-art equipment, high quality, patient-centric. But there was one four-letter word that I thought was incredibly important to the mission of any program, and that is safe. And Brett puts that as well as I do, both from a laboratory standpoint and for patient safety. So I think that's those four-letter words, that four-letter word goes a long way. And
That's
then the other
awesome.
thing I just wanted to just echo is that uh, in the type of patients that we take care of here, I always tell the patients that in our safe, high technology center is that I drive the bus, but the patients are the tour guides and they tell
Hmm.
us where to go. So we don't mandate or dictate what patients do, but rather we will drive them and they tell us where to go as long as it's most
Right.
reasonable and reasonable.
And how big is the practice?
Well, we are just starting. I've been here now a year, seeing patients. So we have a number of patients that are lined up to do IVF, and I'm waiting for the green light.
We are putting the final touches on the lab now as we speak.
Okay.
Um, we're doing the final test and balance on the air system. And then one of our last hurdles is to do our air quality testing. We want to make sure that the air we have going in the lab is super clean with no
Hmm.
volatile organic compounds. And so as soon as I'm convinced that we have quality air coming into the lab, which this test will tell us, then we can start doing our quality control on all the incubators
Hmm.
by doing some preliminary cultures first, and then we can start bringing patients in through the lab.
That's amazing. Well, I know I'm going to be whenever you guys have your opening, and we'll share pictures with our listeners so they could see your new facility once it's open
Oh, we will
officially.
be very happy to host you to come see our lab. Both Stephen and I are extremely proud of this clinic and the laboratory of how it is now. And so we would love to be able to show it off to you all.
Looking forward to it. And since we're speaking now, Dr. Reggio, where are you from? Like, are you a South Florida native, or did you come down here to start the clinic for the lab
Yes,
component?
all three. I was from New Orleans.
Okay.
Grew up in New Orleans, and moved to South Florida. It was in 2020, right at the
Hmm.
pandemic. I
Yeah.
was invited to come down and open up a lab in Coral Gables with Santa Monica Fertility.
Okay.
And then several years later, I had an opportunity to come here and open up a beautiful IVF practice in Weston with
Okay.
Dr. Lindheim.
And what is the role of the lab director?
We make sure that we have a safe environment to culture our patients' embryos. So I oversee every step of the process from processing the sperm sample from the partner to retrieving the eggs from the follicular fluid that Dr. Lindheim would aspirate from the ovary,
Mhm.
uh, mixing the sperm with the egg if it's an insemination case, or doing an ICSI procedure, which is when we inject a single sperm into the egg, and then the entire culture period, um, freezing any excess embryos that we don't transfer.
Mhm.
Uh, we will have cases where we want to do some pre-implantation genetic testing on these
Right.
embryos. So
Okay. Is that
I'll do
something you
a
do
cross.
at your facility or is that sent out? I wasn't
We
sure.
we do the actual biopsies here.
Okay.
Marla, but the cells that we remove from the embryos, we have to send those off to a specialized genetic testing lab to give us the results.
Right. Okay.
And,
That makes sense.
and part of the job of the lab director is to make sure that paperwork is all straight for those embryos that we biopsy, that we match up the biopsied sample to the biopsied embryos, and there's no mismatches. So we've got a number of safeguards to make sure there are no mismatches or crosses. So
Is the
it's
genetic testing something done across the board, or is it a case by case basis?
great question. It is a case by case basis. We know from studies that PGT is not beneficial for a certain subset of patients. Normally, those are our younger patients that
Mm.
normally their eggs are much more robust in comparison to an older patient's eggs. And
And
so
what's
when
considered old in the eyes of a physician?
probably over 37 is
No
when
judgment.
PGT
Okay.
really starts to become meaningful. But there are cases when younger patients might want to take advantage of testing their embryos if they want to do family balancing or if they have known
Okay.
genetic abnormalities in their in their bloodline. We can weed
Okay.
out those embryos that might have a genetic abnormality that they might be predisposed to.
Okay. So it just really depends on the case at hand and what their needs are. Like you said, you drive the bus and you see what they like to do.
Yep.
And
Yeah,
Dr. L, yeah, go ahead.
I was going to say sometimes patients come in with a preordained notion that they want to do something and or they heard that it's the right thing to do and the flip side is to try to talk patients out of doing too much
Mm,
for IVF because they think they need to do PGT, for example, but
right.
it's a challenge trying to convince patients from a scientific standpoint that they don't need something when they come in thinking they do, but at the end of the day, if that's what they want, we will just drive the bus for them.
Right. I mean, that's the difference between Googling something and actually speaking to an experienced physician about what's best. How often are people asking for double embryo transfers? I actually had someone ask me just today, like, is that something I can do? And my thought is physicians aren't necessarily encouraging it. What are your thoughts on double embryo transfers?
Well, I think it's state dependent. Florida is not a mandated state, as opposed to Illinois or Massachusetts. It's a lot easier to justify in a patient's mind doing a single embryo transfer when IVF may be a covered benefit. Uh, in the state of
Mm,
Florida, a lot of patients come in with this, hey, two for the price of one, three for the price of one, let me get
right.
it over with. And my first comment is, let me just show you what our national guideline recommendations are. Um, and so this is what is recommended. And then I say, what I want you to do is I want you to YouTube twins and triplets in the NICU. And then
Mm,
I want you to
that'll do
YouTube
it.
toddlers, when you're trying to get them to the baseball game and get them to piano lessons and to, some other sporting event. And then I want you to come back to me and then let's talk about doing more than a single transfer.
Right.
And that oftentimes works.
Add
It's
in
very
no nap, skipped nap, and an outing for the day.
so, but the answer to it is there are still some patients that come in, even against recommendations and not that I wouldn't say that I wouldn't do it. We would actually make them consent that it's against start recommendations.
Right.
I would, I mean, I will tell you, I wouldn't go more than any two euploid embryos in anyone, but I really try hard to. Um, explain why a patient should do single embryo transfers. The uterus was meant to carry one embryo,
Right.
um, one baby, and there are people that still ask for it.
And
Right.
it wasn't too long ago that we had to do double embryo transfer in order to maintain a reasonable pregnancy rate. And the cause was we didn't have a really robust culture system like we have now, and we didn't have the tools at our disposals that we have now to
And by
weed out.
culture, you mean laboratory culture, right?
Exactly. Yes.
Okay.
Yes. So it was more difficult then 10 years ago to have an embryo grow in culture to the blastocyst stage. And once an embryo reaches that stage, it's pretty much proven itself that it can make it all the way to that very important stage of development. But it was difficult to get a fair amount of embryos to do that. They would
Hmm.
simply rest in culture. They needed to be back into the environment of the uterus. And we didn't have those technologies that we have now to get those embryos to grow to the blastocyst stage. So we would transfer embryos on day 3 of development.
Okay.
But the problem with that is that the embryo is it's a big unknown. It might look beautiful on day 3, and 8 cells in that embryo. It might look really nice, but it might not have any potential at all. So to avoid a failure, we would transfer 2 or 3 embryos in the hope
I
that one
see.
of them would be good. And so we would get decent pregnancy rates, but we had an unacceptably high twinning rate. And over time, that caught up with everybody. The insurance companies were making a stink. Uh, as Steve mentioned, it's extremely tough on the children to be born a twin. It's they're underweight. It's tough on mom. It's tough on dad
Premature,
to
right. And
wallet.
with surrogacy, you have expenses of bed rest and childcare, and
Yep.
it's a lot to think about.
And so
Well,
now that we can grow to the blastocyst stage with great frequencies, and have the ability to weed out any chromosomally abnormal embryos.
Right.
The recommendation is strongly, solidly single embryo transfer.
And
And if
now
you
are
don't
most
get
embryos
pregnant,
5 days? Sorry to interrupt. Is it mostly no more 3 day typically, or?
it's rare that we would transfer an embryo on day 3. Even if they only had 1 or 2 embryos in the culture dish on day 3, I would still fight to let's let it culture out another couple of days. If it makes
Mhm.
blastocyst in the dish,
Yeah,
it has a very
the
strong chance
chances.
of implanting in mom. If it doesn't make it to the blastocyst stage, I can almost guarantee you would not have made a blastocyst stage embryo if we would have transferred it on day 3 into the uterus.
so the
Interesting.
caveat to that is that if a patient has done multiple cycles and perhaps arrests embryos, um, continuously arrests embryos, and they are not able to close that chapter and move on to egg donation, for example. One of the things that on the clinical side, after discussion with Brett, would be to say, let's use the uterus as a culture system, and we're going to do a cleavage stage transfer. Those are less likely to happen, but it's still on the radar as an option for patients.
When does that happen in the cycle of the embryo, the cleavage cycle?
Day
Oh, that's
three.
the day 3. Okay, got it.
So
Very
you
interesting.
if I could just interject one point,
Please, yeah.
you raised gestational surrogacy and utilizing single versus double transfers, and it's very interesting that international versus domestic surrogacy is a very significant difference in the number of embryos desired because it's so incredibly expensive for international surrogacy. So
Right.
a lot want double. And then, interestingly, when you have same-sex males using a gestational carrier, oftentimes they want to have genetics from both of
One
the
of each.
one of each. So it does posture a significant challenge because sometimes you may not get that carrier to come back. So, as you
Yeah.
know,
I
those
see
rates
the
are
same
very different.
trends, and I'm seeing a trend of people that want double embryo transfers really just cycling 2 different surrogates sometimes. I mean, it's obviously the expense is much greater, but the pregnancy risk is much lower.
Yes, that from a medical standpoint is a much safer way. It's a lot more expensive,
Right.
uh, but certainly that would make me feel better from a medical standpoint. It would make, I think, you feel better.
Right.
Yeah.
Absolutely. I agree 100%.
And for either one of you that wants to answer, I was always fascinated on the grading of the embryos. Like, how much should we take it to heart? And I'm obviously not a doctor, but I was told, like, even if they say it's AA, it doesn't mean it's a slam dunk. So, and you shouldn't get
You're
too wrapped up in that.
you're exactly right. It is subjective. And for years we've used the standardized Gardner grading system made famous by Sir David Gardner. He's known now as. And it's a number followed by 2 letters. And so the number 1 through 6 describes the degree of expansion of that blastocyst, 1 being no expansion and 6 being a completely hatched.
Oh, okay.
blastocyst. And then the first letter can be A, B, or C, and that describes the health of the inner cell mass. And that's the first cell type in the embryo. There's two cell types of the blastocyst. There's the inner cell mass that becomes the baby, and then there's the trophectoderm cells that go on and make placenta. And so
Hmm.
we grade those A, B, or C. So a 6AA would be the best embryo possible. It's fully hatched out of the zona. It's got an A grade inner cell mass, and it's got an A grade trophectoderm cells. Slam dunk, right? You transfer that embryo, she doesn't get pregnant. The reason is it could have been chromosomally abnormal. So
Mm.
rather than just rely on these morphologic parameters that we can look at, the embryo size and the way the cells look, we can test those embryos with the PGT. And just recently now, we can also use AI to help us choose the right embryo. The
With that,
artificial
without the testing, with the genetic testing, or in lieu of, or with it, I guess how.
Right. So the genetic testing would always trump what the AI says. But if the patient chooses not to have PGT,
Mm.
and and if it's up to me to choose which is the best embryo to transfer, she has four embryos to choose from. I would pick the best embryo, and hopefully the AI would say that is the best embryo. And
Wow.
usually it does. In those cases, though, where the AI says, well, embryo number two is the best embryo of these three embryos, let's transfer that one first. And if there's no real difference, other than, slight subjectivity on the embryologist part, if you let the AI choose the embryo, that's what we're working on now, is what's the concordance there? How often is the AI correct? So we're starting to
Right.
see some really great data where AI can pick out these subtleties that we just can't. And
That's
it's starting
so
to be very
fascinating.
predictive of a normal, healthy pregnancy, is being able to use
Hmm.
AI as one of the tools to help us choose the embryo to transfer.
Wow.
Another thing that is good that time lapse as well as AI may be able to do better than Brett can do is looking at the delta or the time change or the rate of the change, because something at the end can look the same as it did the as another embryo, but it may have met at different time points sooner
Hmm.
or faster or perhaps maybe delayed. You shouldn't see something too quickly. And so
Wow.
AI, as coupled with time lapse, adds that benefit that just looking at a snapshot picture can provide
Wow, it's
additional information.
fascinating. I mean, the success rates you think are just going to continue to improve with all this, the advancements.
Yeah, and I think a different benchmark that we're all using are referred to instead of your pregnancy rates or your live birth rate is really it's really cumulative live births.
Hmm.
Because a whole cycle is really the conglomeration of all of your embryo transfers. So I like to quote patients now, your cumulative chances of getting pregnant, because they may have multiple transfers. Because a young woman less than 35 who has a euploid embryo, it's almost a 95% cumulative live birth rate. With about 5% of the time, we're just not able to figure it out. So
Right.
so very different definitions than we used just even a couple of years ago.
Hmm. And what are some of the emerging, I mean, you mentioned some AI use, any other really cool IVF advancements that you're excited about or seeing or using at your clinic?
Well,
Go ahead.
on a clinical standpoint, we're trying to move away from some of the injectable medications. There are three medications that we use to recruit eggs, to prevent ovulation, and to what we call it trigger or finish the final maturation of
Ooh,
eggs.
and that one really hurts. I remember.
Yeah, and actually we are using it off label as a sub-Q, but there are some of the medications. Uh, think for example, elagolix is a GnRH antagonist that can be given orally. Many of us are using other oral-like type medications. So instead of using sub-Q or the IM shots, we're moving away and it's trending towards that. So that's
That's nice.
clinical changes that are helping patients. There's a new technology that's out that patients can do self home monitoring with their estrogen levels as well as ultrasounds
Wow.
that get fed in. So the patients at some point may not even end up showing up in the clinic, just all the
Oh,
stuff.
that's like so good, but also so tempting to test, like often at home. Like I was
Yeah,
afraid for my surrogate to test herself at home, but we did, but still it's good. Information is knowledge. It's helpful.
so those are on the clinical advances. Have it on your side.
Well, I was also going to mention there AI is also useful on your side for managing the cycle. Managing one patient cycle is challenging enough, but when you have a number of patients in that batch going through, sometimes it can be a little daunting, not for an expert like Stephen, of course,
Right,
but
of course. To
AI can
max.
help manage that stimulation cycle. It's been fed so much information that these large language models now can predict the best time to trigger based on a number of different parameters that it's fed in, and it can also help even out the very, very busy days against the not so busy days. So instead of having a one day where you have 4 or 5 retrievals and the next 2 days you don't have any retrievals, it kind of evens it out. So you might have two
Mm,
retrievals per day per week, and
that's great.
that will even out the workflow using AI that way, which doesn't compromise the cycle. That's the goal.
Of course. Right. You don't
That's
want to do it just for convenience. It has to be for the success.
exactly. Yeah, that's exactly
I
right.
mean, it all sounds super exciting and obviously very cutting edge, especially, at your facility. So I think that the people of South Florida, I would imagine from around the world will benefit from the services that you're providing. So thank you. And we're so glad you're here in South Florida.
We are glad we're here too. I mentioned at the top of this webinar that I've been here 6 years now, and I consider South Florida paradise. I absolutely love where we're living. This is a great place.
It's awesome. Yeah. I mean, the summer's a little hot, but overall, it's great.
So,
Um,
a shout out to you is that, when I identify practices or where I go, well, one, I'm very lucky to be working with Brett because not only is he funny and really intelligent, and I enjoy those qualities of him as well. But also a shout out to you is that I third party reproduction is really important. Reproductive law is a unappreciated area in our industry, and to have somebody as knowledgeable as you or as passionate as you, because many of us don't give it a thought or poo-poo it or just give it minimalistic amount of time. And so I really appreciate
thank
your
you.
passion. And so thank you.
I appreciate that very much. Well, it's such a pleasure. I'm so glad that we connected. We were able to do this interview. And for our listeners that want to learn more about Elite IVF Solutions, what is the best way to find information on the clinic or to contact you?
One, you can go to our website at IVF Elite Solutions
Okay,
.com, and they can all make appointments to come in and see me, um,
great.
and go from there.
Wonderful. And I can just speak from personal referrals that I've sent you that you are extremely accessible and easy to contact. And for an IVF patient, I think that is just massively important. It's stressful and being able to have good communication is really critical, I think.
Thank you.
Well, thank you both so much for your time, and we can't wait to share more about your clinic with our listeners. And thank you for all the work that you're doing in the IVF community.
Thanks for having us, Marla. We certainly appreciate it.
Thank you.
My pleasure. Thank you.
Bye.